Good evening, everybody. Welcome to this webinar entitled Meet the Expert, Real-World Data in VTE, the RIETE Registry. My name is David Jiménez. I'm a respiratory physician at Ramon y Cajal Hospital, and I'm more than pleased to introduce my very good friend and colleague, Professor Manuel Monreal. He's an internist from Germans Trias y Pujol Hospital and the father of the RIETE Registry. Welcome, Manuel.
Thank you, David.
Well, we have a busy agenda today. During the first 20 minutes, we will be discussing different issues around the RIETE Registry, and we will dedicate the last 10 minutes to answer your questions, and you can submit your questions anytime through the website. So, Manuel, my first question is, why did you decide to create the RIETE Registry?
Well, I still remember the day when everything started. I was in the hospital. I was on duty. It was a Sunday afternoon, and I was urgently called to the neurology service. There was a lady there that has been admitted 1 week before because of spontaneous bleeding in the brain. And I was called because she suddenly developed chest pain, respiratory insufficiency, and so on, and she was diagnosed with an acute pulmonary embolism. My problem was how to manage, how to prescribe anticoagulants to a patient that has a severe bleeding in the brain just 7 days before.
Because, Manuel, these cases are not so infrequent in clinical practice.
They are not that infrequently. We, several years later, analyzed our database and learned that in real life, 20%, 1 in every 5 patients with venous thromboembolism has at least one of the common exclusion criteria to be involved in randomized trials. Recent major bleeding, thrombocytopenia, severe renal insufficiency, pregnancy, liver insufficiency, disseminated malignancy. These patients are not uncommon, 1 in every 5 in real life. And of course they have a much worse outcome during the course of anticoagulant therapy. So these patients are not infrequent, 1 in every 5, and have a much worse outcome than what we learn from randomized trials. And there is no evidence about how to manage them. Right. So my idea was from the lady with pulmonary embolism shortly after an intracerebral bleeding. My idea was that if we were able, we in the hospital, together with other colleagues, friends, experts on treating patients with VTE, if we were able to put all our consecutive patients with VTE in a unique database, maybe we will be able over time to gather information on a significant, a substantial amount of patients so as to learn a little bit more about the natural history of VTE in these heterogeneous subgroups of patients that never appear in the guidelines, in the literature. And 5 years later, we learned that we published our first study on this topic, VTE after a major bleeding, and we learned that 2 weeks makes the difference. All those patients developing a VTE less than 15 days before a major bleeding have a much worse outcome, a much higher mortality rate than patients with VTE and no recent bleeding. However, for those patients with recent bleeding in the brain, gastrointestinal, or wherever, but with a difference, a time over 2 weeks between the major bleeding and the VTE event, the outcome is absolutely comparable to patients without VTE, and we can treat these patients with anticoagulants without the risk, the increased risk for bleeding.
Amazing.
that's what we learned, because at that very moment I went to the internet, I went to the guidelines, I went to look for cohorts of patients with the same clinical scenario, and we found nothing. And my question, David, for you is why there is no recommendation, no suggestion about how to treat, how to manage these patients in the guidelines?